I invite Dr. Bharti he's the Bhishma Pitamaya of refractive surgery of India, and he will be sharing his experience of long-term complication and results of ICL.
No complication. Complication. My
Long-term,
father has already talked.
long-term issues.
So I have not created any complication. I'll be discussing results. Thank you, Purendra, for having me here. And but the slides do not work somehow. But so single hole in the center is very important. It allows the flow of aqueous and prevents the happening of cataract. And this is probably a video which is how I want to do the ICL. So first mark the axis at which you want to implant, make a side port, and the first thing I want to do is to put a anesthetic to anesthetize the iris and keep the pupil dilated. Second is to inject some viscoelastic, and you can see that these chains of viscoelastic are still persisting. So that is very important. Do not overfill, and you should be able to see the chains of the viscoelastic. Make the main port, which is about 3.2 millimeter, and then for stability of ICL over the this stick, I put a little bit of viscoelastic so that it sticks, and even if you rotate the stick, it doesn't fall. And then you inject and pull it. Now pulling is important. You pull the cartridge back and not the holding forceps in forward, and then inject gradually. It goes in, inject it in front of the iris. Do not go behind the iris. And then first you press the posterior lip to take the viscoelastic out from behind the ICL. This is very important. So once you have taken the viscoelastic from behind the ICL, then you can inject ICL in front, the viscoelastic in front, so that it is pushed behind, and then rotate, and while rotating keep on pushing it behind the iris so that you reach, as per your comfort, you can make it clockwise or counterclockwise. So that is one way. And then you can press, don't press it in the center, just press it at the edge, and check that your viscoelastic is from the main hole, main fenestration. You yeah, yeah. Go ahead. So you were taking pictures. You have excluded me from that picture. That's not fair. That's not fair. Let me speak. Another. Right. So then that ends the procedure. The safety concern is regarding the sizing and vault, and they are most important, so that you have to good size and good vault. Excessive vault will cause block, endothelial cell loss, pigment dispersion, and elevated intraocular pressure, and insufficient vault is going to cause cataract. Overall, lens diameter is selected for implantation in order to achieve a safe level of vault. Is what is the most important thing is whether you want to check sulcus to sulcus or white to white, and no methodology has proven superior to white to white. So whatever you do, whatever way you want to check white to white, it has to be white to white and not black to black or blue to blue. So this is what it is. Now long-term data available for post-approval study of the implantable collamer lens conducted under the US FDA has provided additional information for the cataract, IOP, and endothelial cell loss. So out of 526 eyes, 31 eyes develop anterior subcapsular opacities, and 5 of these developed visually significant. So that is very important to understand that a small vault is going to cause lot of trouble. And in regarding the incidence of cataract, also incident older age and myopia, high myopia is important factor. And also this is you have to take care of the selection of the patient like that. Central port, as I have already told, it takes care of the posterior subcapsular opacity, anterior subcapsular opacities. Incidence of elevated IOP is 3.2%, and this is has to be controlled immediately with iridotomy and retained viscoelastic causing increased IOP. You know, it can resolve itself or you have to wash it. Endothelial cell loss is about 1.2% annual decrease after the normal eyes, and this is 6.46% decrease in endothelial cell density after the ICL implant. So expected age-related loss of endothelial cell density is 0.6%. So this is definite that there is little bit of endothelial cell loss after the ICL. Fluid dynamics is the laboratory studies have shown that 360 micron hole size is close to ideal for prevention of cataract and to maintain sufficient aqueous flow. There are optical effects. Majority or maybe 100% of the patient will complain that there is some photic phenomena because of this, but they probably mostly reduce, and also because the patient gets used to them and stop complaining. So effectiveness out of 1905I, efficacy index of 1.04% and refractive correction was within 0.5% in 90.8%, close to 91%. That is excellent result. And 1410 eyes reported one line or no line of CDBA lost or gained with a weighted average follow-up of 14 months. Only 0.2% of the eyes lost two or more lines of CDVA, which is 95.5% maintained or gained line. Transient rise in IOP is possible, but mostly it is controlled by itself within a month. Endothelial cell density we have already talked. So there is a phakic intraocular lens can provide optically superb correction, high level of postoperative undercorrected visual acuity, refractive predictability and stability, very efficacious IOICL. Safety data reduces rates, suggests reduced rates of anterior subcapsular cataract and improved safety and effectiveness across a broad range of refractive errors make ICL an attractive option for surgeons. Thank you very much.
Any question? We can take one question with all the panelists are here, all the
They are so well
senior
explained,
instructors.
my dear.
I
Nobody has
think
any
everything
question.
has been covered. They are hungry and they want to go for lunch, I think.